So with that, we call upon the fifth video of the day. Video number 18, From Glare to Relief. We would like to call upon the presenting author, Dr. Vanashree Mahesh Nair.
This is a case of a 65 years old male who presented with a long-standing traumatic mydriasis cataract with suspected zonal adhesions. His visual acuity was 6/36, not improving with glasses. He had complaints of glare and disturbance in bright light. OCT showed a thin ERM on the macula and the biometry revealed significant corneal astigmatism. Now, if only the cataract surgery is planned, the patient will not benefit much because of a large pupil causing suboptimal visual recovery and postoperative care. So I thought, let's tackle the cataract with phacoemulsification. The regular astigmatism can be tackled with the toric IOL, and the large mydriasis can be tackled using single-pass pour-through pupilloplasty. I begin the case with the toric marking, the side port incisions, and initiate the capsulorhexis with my 26 gauge needle cystitome. I change over to microrhexis forceps to prevent any stress on the zonules which were suspected to be weak. I change over to the other hand and complete the rhexis. I make the main wound into a gentle hydrodissection, gently rotated the nucleus to ensure that it is free from the capsule. I began phacoemulsification with the stop and chop technique, divided the nucleus into two equal halves. Then I did the sub-chopping using the vertical chop technique to make smaller pieces in both the heminuclei. Each of the small chunk was pulled out of the bag and phacoemulsified in the iris plane. Once the phacoemulsification was complete, cortex aspiration was done using bimanual technique. The cortex is pulled towards the center gently to prevent undue stress on the zonules. I decided to implant a capsular tension ring to give support to the bag. A single piece toric IOL was implanted into the bag and dialed into position. AC was washed and the wounds were hydrated and the pupil was constricted using pilocarpine. Let's understand how the single pass pour-through technique works on this eye model. I pass the needle through the paracentesis, pass it through the proximal iris and the distal iris, and then externalize the needle through the opposite paracentesis. I use a hook-like instrument to create a loop and pull it out through the proximal paracentesis. Now the proximal end of the suture is passed through this loop 4 times and the distal and the proximal end are pulled in the opposite direction so that the loops pass inside and create a knot. So I began the procedure by creating extra paracentesis. The straight 90 proline was passed through this paracentesis and MST forceps was used to hold the edge of the iris so that the needle could be passed. Another side port was made for the MST forceps to pass. The iris edge was held using the MST forceps and a 27 gauge needle was passed through the iris. The straight needle was then railroaded out through the needle. Now to create the loop, the MST forceps was used to bring the distal end of the suture closer so the Krugman's hook could pass and bring out a loop through the proximal paracentesis. Now the suture was passed through this loop 4 times to create 4 throws. The distal and the proximal end of the sutures are pulled in the opposite direction. Thus a knot was created and the pupillary margin was brought close together. Now for the second suture, the side port was used to pass the straight needle through the iris tissue, and on the distal side, with the support of the MST forceps, the straight needle was passed through the edge of the iris and pulled out from the paracentesis. The loop was brought out through the proximal end using a microrhexis forceps, and the 4 throws were passed through the loop to create the knot, which would be passed inside by pulling the distal and the proximal end of the sutures. Once the knot is passed inside and tightened, the remaining ends of the suture are cut using micro scissors. The pupil size looked satisfactory. However, there was a large gap in the inferior part of the eye which would cause glare to the patient. So I planned one more knot using the same 4-throw technique so that the iris tissue would be better approximated inferiorly. The same steps were followed using the straight Prolene needle. Loop was created and brought out through the proximal end. 4 throws were made around this loop. The knot was slid inside, the extra ends cut, and now the iris was well approximated. The AC was cleared of viscoelastic. The side ports were well hydrated. Day 5 slit lamp image showed a well settled eye with a post-op vision of 6/9 unaided. Thus, a careful planning and execution led to a happy patient. Thank you.
Thank you, Vanashree. Dr. Prashant, I think you have some experience in iridoplasty. Please.
Yeah. Thank you. Vanashree, wonderful video, basically. Very nice videos. Yeah, for any pupil, basically, if you have a mydriasis as big as this, you should do pupilloplasty. That is a very loud and clear message, which I would also echo with you. And a wonderfully done surgery is beautiful.
I think the best part was the way you showed in a diagrammatic manner how to do it, because when people show you surgically, then all the sutures kind of get confused and then you can't depict it. But I think this is one of the best diagrammatic representation of how to, an explanation of how to do it.
Ma'am, that was the idea actually. When I was editing the video, I realized who want to learn, the people who want to learn how to do pupilloplasty, it's very confusing when you see the surgical video directly. So that's why I made that model, and thank you.
Yeah, very nice video, Vanashree. I just wanted to compliment you for that.
Thank you, sir.
But the only thing is, if you have such a huge traumatic mydriasis, what I used to do a lot of SFTs, easy to do SFT, but only thing is multiple times you have to make sure. So I do the encerclage, which is actually like a purse string. So you can maintain the size of the pupil as well. It is more difficult than SFT. Only thing is the encerclage is also easy because it's on one side you go through. So it's every procedure there is a learning curve. But it is really hats off to you, and hats off to Amar for bringing this.
Thank you, sir.
One suggestion, like while doing this or while doing iododialysis repair, one alternate thing will be when you are making paracentesis, I think you will be having a posterior segment surgeon in your place. Posterior segment surgeons. Posterior segment surgeons. We are surgeons.
Yes, sir.
So you can borrow either a 23 or a 27 non-valved cannulas. When we put it into the paracentesis, the negotiation of the needle is very smooth, because in this sometimes it goes through the stroma of the what do you call?
Yeah, that's
the
called Naresh, the trocar assisted.
Yes.
We do the iododialysis repair as well.
That will be slightly
Yes.
easier actually.
Nice video. Just one query. Was there a subluxus and you put a CTR after the phaco was done?
It was more of a protective measure actually,
As a
because I didn't get any
prophylactic
subluxation,
purpose,
but
yeah.
since it was a history of trauma, as a safety factor.
Okay. Thank you.